All right, so if everybody could have their seat, we want to get started. I want to just provide a brief overview of Lewis University and the programs we offer, and then followed by that, we have our keynote speaker, Dr. Susan Swart, who's going to also talk to us. And we have some great food and beverages afterwards. And we're going to be able to give you tours of our Oak Brook facility, our health assessment lab, and our acute care lab. People are set to show you around, so I hope that you stay after the speaker and have some food and beverage and take a look around at our facility here. We're very blessed to have such a great location. It's very centralized for Chicagoland area. And I want to note that we're celebrating 50 years of nursing education at Lewis. So that is quite an accomplishment. We are a very well-known, stellar facility with, again, all that experience providing and preparing nurses. So our mission and vision is really aligned of that of the universities, and that is of the Catholic and Lasallian heritage for the nursing department. We really believe in transforming our students to address problems holistically with individuals, the population. We like them to think systems when they're thinking about change agents. We always bring in that health equity, peace, and social justice while addressing, again, those local and global health needs of our community. We have a BSN program, an MSN program, and our doctorate program. You can see our vision here for each of those programs. They're well aligned, as you can see, as students move from the BSN level all the way up to the doctorate level. And so I just wanted to make sure that you guys really knew that, because this is really who we are, and it guides everything that we do at Lewis University. So some might ask, why Lewis? Well, one thing is we have outstanding NCLEX pass scores. In the 90s, we have been for years. We've doing a really great job there. Again, at 50 years plus of quality. We have acute care simulation labs here at the Oak Brook campus, also at Romeoville. Here's a picture here at Oak Brook that I hope that you guys will come and see after the presentation today. We've got 2 acute care simulation labs, and we've got a whole row of 7 to 8 different patient exam rooms where our students will practice those health assessment skills. We have small interactive classes here at Lewis, which is great. The faculty know the students' names. We have, again, not only excellent NCLEX pass rates, but also certification pass rates for our NP students. Our FNP rate was at 95% pass rate. The other thing that I think is really great about Lewis is our employer tuition discounts. That's huge. I know we really value the partnerships we have with our clinical agencies. We couldn't do what we do without them. It is a true partnership. And so part of that is being able to give back, and they have tuition discounts to come to Lewis. If you go to our website, we can share that with you. Also, after today, we have our admission counselors here that are willing to answer questions and share those partnerships. Also, alumni tuition discounts. So if you're a flyer, if you came for your bachelor's, you can come for your master's and also get a 20% discount off of tuition, which is a really great deal. So it pays to be a flyer. The other thing that's really great about our program, especially in the graduate, we can earn our degree at our own pace. So most students will finish that master's degree in about 3.5 years. But if you want to speed it up, you can do that. If you want to take a little bit longer, you want to do 5 years, you can do that. So it's really something that can happen at your own pace. We're very flexible about that. We know that everyone is a working professional, and so that is possible. Also, of course, I have to mention that we are CCNE accredited, of course. So our Bachelor of Science in Nursing program is ranked in the top 10 nursing programs in the state of Illinois. I even put the link there so you could see that, but our graduates are really prepared with that leadership and critical thinking skills needed for today's rapidly changing healthcare environment. We just had a meeting with our clinical partners prior to this, and they provided some really good feedback, which we value, and it is, again, a continuous communication to make sure that we are really producing the nursing students that are needed out there to care for patients. We also offer, in addition to the traditional BSN program, we also offer an RN to BSN program. And this is an accelerated format. It's 8 weeks. It's fully online. It's for those who might have gotten their registered nurse at an associate's degree and want to get their bachelor's. We do that here at Lewis. We also have an accelerated bachelor's in nursing program. And so what that is someone who might have a bachelor's degree in maybe psychology or biology or chemistry, and they already got a bachelor's, but they're like, gosh, I want to change careers. I want to be a nurse now. So this accelerated program takes that into account. We utilize those courses that they took for their gen eds with their first bachelor's degree. They're able to take just the nursing courses and then be able to be eligible to sit for the NCLEX and work as a nurse when they finish that program as well. We're actually offering those courses. We're starting this fall, going to be offering one of them here at the Oak Brook campus as well. So again, our facilities are really well centered here in the Chicagoland area. And then our Master of Science in Nursing program. You can choose from 7 different specializations here at Lewis. You can see we have everything from health care systems leadership to nursing education, school nurse, to our 4 different NP tracks. I know the psychiatric mental health nurse practitioner track is becoming very popular as we see the need for mental health in our community. In addition to these 7 tracks, we do have a bridge program for someone who has a bachelor's degree and has their RN associate's degree and maybe want to go straight to the MSN. They can do that. We have a bridge program for that. Plus, we also have an MSN MBA option, meaning if you're interested in healthcare systems leadership and you'd also like to get your MBA, you can do that at the same time for that program, which is really cool. So I think this is very unique that Lewis has this many options. And the great thing is sometimes students come in and they start in one track and then they might change their mind, and that's okay. We allow that. We really want to make sure that they get out with a degree that they can use, that they're going to value, and give back to the community. So lots of options. We also offer certificates. So in all of those different specialty areas, maybe you already have a master's degree and you're interested in going in a different track. So for example, I'm a family nurse practitioner and I was practicing as a FNP and decided, gosh, I really love this education thing, right? But I want to be the best nurse educator I can. So I was one of those people who went back and got a certificate or a non-degree program in nursing education. I took those courses that helped me to also be an educator in addition to an FNP. And so we have a lot of students that will come back and maybe they studied as a family nurse practitioner, but now they're interested into providing mental health care, and they come back and get the certificate to be able to sit for the psychiatric mental health NP exam and practice that way. And so that's another option for students who are interested in maybe just changing their specialty area. They can do that. And then we have our Doctorate of Nursing Practice program. So this is our terminal degree. It is 30 credits and it's offered fully online. It really focuses on that quality improvement, evidence-based practice, and that systems approach to caring for the public. And again, if you get your master's at Lewis, it's a very seamless transition to the DNP. If you get your master's somewhere else, you can still come in. It's very easy to just come in and start that track. Again, I think what I hear from students most about our DNP is that they appreciate it being all online. And so that's really helpful. So here's some information about how to apply and receive more information. I've put up here our admissions line for undergraduate, Carrie, and for graduate, we have Nancy Wixton and their contact information if there's more questions. But I'd also like to take questions from the audience. If there's any questions you had about Lewis or our programs, I wanted to introduce, in addition to myself, again, I'm Dr. Pam Taylor. I'm the chair of the graduate nursing program here at Lewis. But we also have Dr. Janine Haberman, who's with us today, and she is chair of our undergraduate nursing program. And then we also have our dean. She's in the back. That is Dr. Muller. She is dean of the College of Nursing and Health Sciences. So we have a really great crew, a lot of support, that we support each other. And so I just wanted to open up and see if there's any questions in regards to either the undergraduate program or the graduate program that either Dr. Haberman or I could answer for you. It's very quiet. Come on in, come on in. Oh, you're fine. Welcome, welcome. So if there's no questions, again, we'll have our staff out being able to answer your questions today after the session if you want to answer or ask a question one-on-one with them, or I'm sure they're happy if you wanted to call or email them. But before I introduce our featured speaker for today, I did want to mention that this session qualifies for continuing education credit. So by coming and you'll get that 1 CE, it is free, and there's an evaluation form that you'll need to fill out at the end of the session, and then you'll get your certificate. If you're joining us online, that evaluation form will be emailed to you after the session, and then once you turn that in, we will email the certificate back to you as well. And again, I just want to encourage you after the session to enjoy us for some food and drink. They're in 742, which is just at the back of the room here, for some social time, and then there'll be people around being able to give tours of our facility here. So, good. All right, so I have the pleasure of introducing our keynote speaker today. I can't tell you how thrilled I am that we were able to get her to come and speak to our group. It is a real honor and privilege. So Dr. Swart is currently serving her second term as Vice President of the ANA and is the chair of the ANA PAC, so the American Nurses Association. She is an accomplished nurse leader with 25 years of nursing and 16 years of nursing regulation experience. She is the CEO of SYS Consulting Solutions and has served as Executive Director for ANA Illinois and the Illinois Nurses Foundation since 2008. And she also helps with the Illinois Society for Advanced Practice Registered Nurse since 2013. So I don't know how she does it. She's everywhere. Dr. Swart received her doctorate from Olivet Nazarene University in ethical leadership in 2018. She routinely presents and consults on scope of practice issues, ethics, nursing regulation, and public policy development. She is known for her coalition building skills, innovative leadership approaches, and building successful partnerships to advance the nursing profession. Dr. Swart believes that as a licensed registered nurse, she has a professional responsibility to actively engage and shape the profession and improve healthcare for all people. It is her life's mission to foster nurse empowerment and to help ensure that nurses are at the table whenever health policy discussions are occurring. So she's got a busy schedule. She's here with us today, and I know next Tuesday a lot of our nursing students are going to be down in Springfield for our Political Action Day, for our Student Nurses Day, and Dr. Swart will be there too. So thank you for joining us today, and I'm going to hand it over to you.
Okay.
All right.
Thank you.
Okay, and here's the clicker.
Yep, thank you.
All right.
All right, thank you very much for the welcome, and I appreciate you being inside with me for an hour on this beautiful, beautiful day. First nice day, and look at where we're at. I'm going to be talking to you all. I'm a walker and a talker, so we're going to see what we can do here. I am going to be talking to you about things today that I am sure all of you have heard bits and pieces of. It can be a little bit overwhelming. It's overwhelming for me when I talk about all of the things that are going on in the profession, because it's nonstop. The days of us dealing with 1 or 2 regulatory issues at a time are done. And so we have to focus on a lot of stuff. So today is about let's be real. I may say some things to you that you all go, might not agree. I'm okay if people don't agree with me. But I am here to tell you that there are a lot of conversations happening, and if we don't all get into a room, agree or disagree, and have those conversations, other people will be making those decisions for us. So I really enjoy an opportunity to talk to nurses about all of these things. So today's objectives, this is the CE part of me. I've been doing it for way too long, so to remind you of what we're going to try and get through. But we're going to do some pre-pandemic, some post-pandemic, and then just go over what the pluses, minuses, I call it the good, the bad, and the ugly that has come out after we've survived the pandemic. But a snapshot of where we were pre-pandemic, because a lot of the things that we're experiencing today and that we'll continue to experience for the next 5 to 10 years were started prior to the pandemic. They were exacerbated because of the pandemic, and it's only made it worse. So we have to embrace the reality of where we were in order to understand where we are today and where we need to go in the future. So a snapshot. Prior to the pandemic, we were beginning to embrace the use of technology. We were starting to have conversations about telehealth, trying to decide how that worked regulatory-wise, lots of barriers in place. We knew that if we embraced telehealth and the technology, that it would mean we would be able to provide care, but there was still a lot of reluctance to do that. We were just beginning to shift from a fee-for-service system to value-based. We had started that process. I'll be honest, we weren't as far along as we should have been prior to the pandemic, and that was an issue. We were beginning to look at and focus on what we were seeing in the data is the variability of care. And that variability had to do not only with the people providing the care, but also the communities where we were providing that care, and how do we create equity in healthcare. So that really is that piece. We were having conversations about the shift from acute care to back into the community. For nursing wasn't a big deal. I mean, if you think about our roots are in the community. That's where nursing began. And then we shifted into acute care, and now we're going to see more and more positions open up outside of acute care and in our communities. And we already knew, the data showed us that we had a workforce shortage in Illinois specifically. The issue was, prior to the pandemic, our workforce shortages were regional. They were not as across the board as they are now. And so in some parts of the states, they were struggling to recruit nurses, to keep nurses. Chicagoland area really hadn't been as impacted. That's historic. The Chicagoland area is one of the best paying areas for nursing, and they tend to recruit from other areas. So those were the things that we were seeing. Let's talk a little bit specifically about the technology. So when we were sitting around the table having these global conversations, and I would invite any of you that as I'm talking, I'm looking for the next person who is excited by all of this stuff as I am, because we need more of me around the table having these conversations. We really do need to make sure that we have a nurse at every single table where there is regulation happening, because what ends up occurring is they think about nursing as an afterthought, and we can't be an afterthought. We are the largest healthcare profession, and we should be the first profession they think about, not the last one. And so looking at improved accessibility as far as technology, those conversations are happening. We're finding if we use technology appropriately, we have a reduction in errors, we have increased communication with our patients, and our patients are able to communicate with us on a quicker basis. And then the impact of telehealth, especially for the psychiatric mental health services that are needed. Without telehealth, the incidence of suicide that we saw during the pandemic would have increased. It was the ability to pick up an iPad, a phone, and dial and be able to connect with someone, to see somebody's face, to read their expressions, for them to be able to share with us during a crisis that helped us. And we need to keep embracing that. In Springfield, we've done a really good job of putting some of those things that were temporary, permanent, and now we just need to do that at the federal level, so CMS continues to do the reimbursement, because where the money flows, that's where innovation happens. The challenges, as I'm saying, for psychiatric mental health, we saw an increase in being able to see each other, but the challenges are also that we are creating a situation where there's less human-to-human contact. If you have young people in your home or grandchildren and they come over for dinner, what's the first thing they're doing, right? Everybody's head is down, that's the first thing. You go to dinner, have you sat recently and been in a restaurant and watched people as they're eating dinner together? Between bites, right? So we have to figure out that sweet spot of balance, but that's an issue. Privacy and security concerns are going to continue to plague us. Here's the issue. It doesn't matter what we do, people are always looking for a way to cause trouble. So for the issue with cybersecurity, we're going to continue to deal with that. We're going to have to continue to build systems, and then they're going to find a way around that system, and then we're going to have to keep building. But if we're going to embrace that, that's going to be something that we're going to need to do. And for educators, we're going to need to teach your students, and I say our students because I kind of like think of them all as mine, although they're not all mine. We need to teach them when it's appropriate to use technology and when it's appropriate to share things, because we're having a huge issue with oversharing, right? Oversharing to the point where people are losing positions. Oversharing because they didn't think it through. They think it's funny, because that's the new thing. Shock them and make them laugh, right? And the issue is nurses are losing their license, and students who have invested a lot of time and energy into going into programs are being asked to leave programs because they've breached security, breached protocols. Need to be very careful to that. And then there's this just underlying concern. I tend to think 10, 15 years down the pike. That's always where my brain has been. But those who live more in the today, when you start talking about technology and change, they start getting afraid of, so that means my position's going to go away. That means you're not going to need me. So you're going to need less nurses because we're going to start using technology. The issue is we need to be less afraid of that. First of all, there's not enough of us. So anything we can do to help expand our coverage is going to be a great thing. But the other piece to it is we are never going to lose the essence of what nursing is, and that's the human touch. Our ability to communicate and touch people the way that only nurses can do. So there is enough room for us to embrace technology without necessarily being afraid of what that technology is going to do to our profession. For academia, it's about embracing those the pandemic changed how you educated in an instant, and we'll spend some time later talking about how quickly we shifted and what the consequences are of that. We are dealing with those consequences, unintended consequences in some aspect, but in other aspect, I'll be honest to say, I don't know that you're ever going to be successful in turning back the clock, no matter how much we may wish to turn back the clock, and we may wish that all of our students are sitting in front of us the way they used to so we can see their face, they can see us, we can engage with them. I'm not sure that that's going to be the reality. So how do we continue to look at that? How do we deal with the increasing decrease of clinical sites? We were dealing with that prior to the pandemic. That's only been exacerbated. The issue that we have, a lot of the issue that I'm seeing, and I haven't had as much conversation here in the Chicagoland area, but in the southern part of the state, what we're starting to see is systems only inviting people in, especially APRN students. They're only invited in if they're already a part of the system. So if you're an RN, then we'll go ahead and let you have your clinical rotations here. But if you're not an RN in our system, then you can't get your clinical rotations there. And it's becoming more and more. Physicians who we absolutely depend on in order to precept NPs, our APRNs, are being told that they can't precept anyone outside the system. So that's severely limiting our ability to expand our base when we desperately need to expand our base. And we need to better prepare students for practice. And we'll spend some time talking about that, both through technology. I mean, I can remember the debate of how much simulation is too much simulation, right? And the issue is and if you talk to, old-time educators, they're like, they don't learn like we used to. You're right. New students don't learn the way you and I learned, right? Hands-on, doing that. But the issue with technology and with simulation that I've learned to embrace is we can expose students to things that you can't expose them to when you go to clinical. I mean, I can remember my OB rotation. Now, I was a later in life nurse, so I'd already had 2 children. I felt like I'd already experienced that, so I wasn't worried about it. But I remember having students in my group, and there wasn't a baby born in our county the entire 8 weeks we went through our OB rotation. So we watched videos. There was no such thing as simulation the way it was. We watched videos, and that was our clinical rotation for OB. Thank goodness I knew I didn't want to be an OB nurse, so it really didn't impact me. But I thought to myself, with simulation, the more and more we advance, the more and more those mannequins, dummies, whatever you call them, the robots now I think is what they really are, the more they have and we can teach them to expose our students to circumstances that they will never see, the better off our students are and the more prepared they will be for practice. So one of the things that we need to look at as I'm getting ready to talk to you about value-based is the reality of healthcare in the United States, expenditures versus outcomes. Well, if you haven't turned on the TV or haven't listened to an economics projection, we spend more money than any other country on healthcare, and we have poorer outcomes. The only country of the organized countries that they were, and they call them high-income countries. We are the only country that's considered high-income that doesn't have universal healthcare. That we haven't decided as a country that healthcare is a right, that you have a right to have access to healthcare. It's not a privilege. We have the lowest life expectancy at birth, which I think is the saddest thing. And when you look at the overall numbers, we have the lowest outcome. And then when you take into consideration diversity, it gets only worse. So for white Caucasian individuals, those individuals with privilege and money, we have worse outcomes. And then you add in the disparities, and it becomes a huge issue. We have the highest death rate of avoidable and treatable conditions. We have the highest maternal and infant mortality. So not just outcomes that can leave a child or a child and a mother with life-changing conditions, but we have high infant mortality. And you would think, I find that hard to believe in the United States, that that's where we are. We have the highest suicide, one of the highest suicide rates. And then we have the highest rate of individuals with chronic illness. And I will tell you that that is directly tied to the fact that we have lost our way. Nursing has lost its way in being shifted and pulled into 1,000 directions, that prevention is not our focus. That has always been what we have excelled at. And we have to get back to that core piece of who we are. So when you look at value-based payment, and there is a large, although we've decided through regulation this is where we're going, we are taking everybody kicking and screaming. And they are holding on to fee-based because that's where profit is. Because they don't have to worry about what the outcome is. The more care I provide, the more tests I order, the more things that I put my patient through, the more money that comes into my system. Doesn't matter if we have outcomes or we have poor outcomes. Whereas value-based, we are paid because we have high quality, because we have positive outcomes. And that's where we need to go. And that's where nursing, really, our ethics is grounded in value-based when you look at our code of ethics. So we have to figure out how we do that. When reducing care variability, remember I told you there's different aspects. There's operational, and then there's the knowledge piece. So for operational, it's very much tied to the system, right? So that variability is what resources does that system have? That system has a lot of resources, then there's a reduction and reduced care variability. They're going to do really well. And then we have our critical access hospitals in our poorer inner cities and in our rural areas of the state that struggle to provide services. Or if they don't have those services, they're shipping people 100+ miles. There are vast areas of the southern part of the state where they no longer have OB services. So many hospitals closing down OB and labor and delivery services. And the issue is that means that those mothers are driving 100+ miles in order to have their babies. Talk about planning. Gosh forbid. You should, do like my sister and have hers nearly in the parking lot by the time she got there. Pros and cons to centralizing. Lots of conversation that we've embraced and having what we call hubs of excellence, right? Places where you go because that's where you can receive the best service for cancer, the best neurological service, the best stroke service. The issue that we have yet to deal with is the issue of, are those centers of excellence, are they centers of inaccessibility? When you start looking through the lens, and I will tell you that my role in the last 4 years at the American Nurses Association has been an exposure to things that I never thought that I would necessarily be exposed to. And those conversations around healthcare inequities and how many people are doing without. When you are in a small area, and I live 50 miles south of Chicago, in a small 9,000 community, and for the last 13 years I've worked from home. So although I go out and I talk a lot to nurses, I do get a little siloed. So the work in the last 4 years has opened my eyes to things that I've not been aware of before. And health equity is my newest passion of how do we figure out how Susan Swart in Manteno, Illinois has access to this necessary service that someone 80 miles, 100 miles, 200 miles south of where I live also has access to that. Susan Swart with certain financial resources has access. How does everyone have access to that? We've got to figure that out. And social determinants of health are the secret to us understanding that, right? Understanding that our healthcare can be defined by our zip code. Huge issues, huge variability in care when it comes to where you live and the resources. And it's important for faculty because with the conversations we've been having is about the types of students that get brought into programs and how do you diversify those students, because that's what the future needs. We need students who represent the very diverse populations that we have in Illinois. So how do we do that? And when you bring those diverse students in, you bring with them all of those inequities that they've experienced in their communities. What kind of education did they have in elementary school? What kind of high school education? What were they exposed to? What didn't get that your other students? And then how do you build systems to assist them through that process? And knowledge, it is for many, it's the clinical variables that happened. So think about someone working at a rural access facility that has limited exposure to some of the more traumatic life experiences, and we ship them out. I worked in a small community hospital. It was like we took care of everything, and we knew when they said they were going that there was something that we couldn't handle. Well, the issue is the nurses working in that facility, had they been forced to deal with that, we wouldn't have been able, we didn't have the skills. You know, many of the nurses, 10, 15 years, how do you remember all of that if you're not continually, because we know the best practitioners are ones who are exposed to things over and over again. Continuing education can only take us so far. So how do we do that? And here's our spending shifts. So where most of our money used to be spent in acute care and only a small amount in primary care, we know that where we need to be in the future is where most of our money is spent in primary care and in health in the community, with a small amount of money spent in acute care. Because if we do it right, if we help prevent chronic illness, if we help prevent that, then only the truly sick are in our acute care systems. So the workforce shortage, as I laid out, it definitely has been looming for decades. We've known that. I mean, I can remember getting into my associate degree program and I was on a waiting list. Very disappointed that I was on a waiting list, but by the time the summer was over, that waiting list was gone and they were taking everybody. And within just 2 years of me graduating from that program, 2.5, 3 years later, there was a shortage and they weren't able to hire, because the issue was we were being told throughout our program, you know, you need to be realistic, you might need to travel, you might not be able to stay in the community because we've got an abundance of nurses. And by 98, they were saying, nope, forget it, it's everybody is getting hired. There weren't enough positions. And so it was cyclic, right? We always said that the nursing shortage was cyclic, but this is different. What we're experiencing now is different, and it's a generational difference. So pre-pandemic, I talked to you about having those regional shortages. We've had an aging workforce. I mean, I've got data at the end that talks about some of the legislation we're going to do, but nurses are 52 years, average age of a nurse, 52, right? So that doesn't put them very long into the profession, and if you're not recruiting enough, if we don't have enough faculty to bring students into programs, right, all of those issues. And 1/5 of the nurses, now this data here is nationwide data, 1/5 of the nurses who are 52 years of age or older are saying they're going to be retiring in 5 years. We also have, at the same time, I point out the physician shortage, because although many of our physician colleagues still stay in denial of this and they don't want to really talk about it, the issue is it's a huge opening for APRNs, right? So we have to figure out how we educate them, and then we have to figure out how we reduce the burden, the regulatory burden that APRNs are faced with in order to practice appropriately. But we need to realize and embrace that by 2035, there's going to be 124,000 physician openings. There's going to be a shortage. That's huge. And then globally, we have to talk about a global workforce issue. The main piece of it is the shortage that we're dealing with here in the United States. We're still taking people from foreign educated nurses in vast amounts to fill our gaps. The issue is there's a global shortage. So as we continue to take and bring those nurses here, we leave those countries short. And so how do we do that in an ethical manner? Rapid growth of advanced practice registered nurses have been a factor. The issue that, as I'm sitting here and saying, we have a physician shortage and we need to encourage to have more APRNs. The reality is for every APRN that every nurse we convince to go into an APRN program means we have less registered nurses at a time where we don't have enough registered nurses to spare. So how do we deal with that? On average, they equate that we're losing 25,000 registered nurses a year just to graduate programs. So that's a huge factor for us. And the issue for our new RNs is they are going into the bedside and leaving quicker than any other generation and looking for a way out. And we'll talk about what we have to do as a profession to work on that. There are definitely supply and demand issues. Remember, we talked about that shift, that beginning to shift into the community. We're currently dealing with that, where we say we don't have enough registered nurses. There's lots of conversation about how do we fix the staffing crisis in hospitals. And the issue that I hear all the time is, it's not that we don't have enough nurses, we just don't have enough nurses willing to work in those really bad, poor environments. Okay, maybe, because I know it's bad out there. But the issue is as those nurses, what they're leading legislators to believe is that those nurses, if we fix those systems, those nurses will come back. I have no evidence that that's true. As we find and innovate in the community and give nurses the ability to not work 12-hour shifts, to not work holidays and weekends, to not work midnights, I think some of them might want to just stay where they're at. And the issue is we don't have that data. So there's a lot of issues at play, a lot of telehealth going on that isn't going to go away. It's only going to multiply. We have nurses working for insurance industries doing screenings via the iPad, health screenings. They like those jobs. They have flexibility. They get to schedule those meetings when they want. You have nurses working for insurance industries where they're going into people's homes and doing physicals in their homes. So that's a lot of flexibility that we didn't have 10 years ago. Those kind of positions didn't exist. And if they did exist, they were few and far between. So how do we deal with that? And then for education, you all know this. This isn't anything that you haven't been talking about for years, but we have a vast number of really qualified students that are turned away because we don't have enough seats for them. We don't have enough faculty to teach them. So how do we deal with that? Lots of conversations going on. Have spent some time with Dick Durbin in a rural health issue, but he realizes it's much more than rural health after we sat in a room with him talking about the difference between a faculty salary and the salary of the students that they're graduating and what that means and why nurses aren't choosing. Why, Susan, would they not choose to be faculty? Well, let me give you a few reasons why, right? That is a huge piece that we have to deal with. And then besides the faculty shortage, the clinical shortage, right? The clinical placement shortage. Because, and this is where you all being at the table, you all getting to know your legislators, having conversations, they have no clue that we have a ratio when we take students into the clinical setting of how many students can go in with a faculty person in order to be, they're like, well, why don't you just send them in? And it's like, because we have requirements in our Nurse Practice Act that says that this, and they look at you like they have no clue that that exists. Dr. Haberman has been privy to some conversations around changing the pass rate. I mean, they're like, what do you mean nursing schools get penalized if their students don't take the exam fast enough and don't pass? What do you mean? Why do they do that? Lawyers, you don't see law schools getting put on probation because it takes their legal students, their students 5-6 times to take the bar. But trying to, first of all, let's talk about the difference between what lawyers are doing and what nurses are doing, right? And what we do from the minute we exit and we begin our license and we have a patient's life in our hands. And when you start having those conversations, they kind of get it, but that's all part of the issue. They don't understand what we do. On a good day, they don't understand what we do. On the bad days, they've just lost it all. So, I mean, that's the issue, is we've got to do a better job explaining what we offer society as registered nurses and what our profession brings to the table. So some of the pain points that were exposed during the pandemic. So during the pandemic, and we are talking, we're still in it, although we're exiting out, we still are seeing some of this. Well, first of all, right from the get-go, we had a huge surge of patients who got admitted without having enough individuals. So we have this surge of patients. We have a lack of understanding how to manage COVID. It was a brand new first time, right? We were just, when you talk about practicing nursing, we were practicing. We were practicing healthcare because we had no true guidelines on how to treat COVID. And that was born on the backs of those frontline care workers. every failure, every time they lost a patient, they carried that with them. What could I have done differently? What should we have done differently? Having those conversations, huge burden to both physicians, nurses, respiratory tech, anyone working in a hospital setting during that 2020, 2021 timeframe when those numbers were so bad. I can't imagine it. And what do we do for most diseases? We know, we cure it, right? Well, we still don't have a cure 3 years out for what is essentially the worst flu pandemic we've ever had. So how do we deal with that? Medicine cures, nursing prevents, and COVID is right in the middle. Just like, how do we prevent COVID? We've learned a few things, like how to prevent the spread, but nurses focused on that, physicians wanted a cure, and none of us came away satisfied with it. And on top of that, we had extremely unsafe work environments because we weren't prepared for the surge. We weren't prepared for a pandemic. We didn't have enough equipment. We didn't have enough PPE. We had nurses wearing garbage bags to protect themselves. We had nurses, and I keep asking someone to do the research because I want to know if those single-use masks, the N95s, right, the ones that we had that we said were single-use, were they really supposed to be single-use? I don't know. The issue is we don't know. And all of a sudden, we were telling those nurses who were stressed beyond get out because they didn't have enough people working with them. They were working extra shifts. Patients were dying. The ones that were dying, think about it, they held an iPad up in front of that patient so that patient could say goodbye to their loved ones because their loved ones were not allowed at the bedside. I can't imagine. And then on top of that, we didn't provide them enough PPE. And then when the worst of the worst happened, they had to decide which patients were going to be ventilated and which ones were not because they didn't have enough ventilators. In the United States, this is what we were dealing with in healthcare. So those additional resources, I get ahead of myself because I get a little passionate about this, so you'll have to excuse me if I'm already there. But this one talks about the resources. We didn't know where we were going to put patients, right? We closed units down. We didn't have elective procedures. We turned ortho units into COVID units, ortho nurses into COVID nurses instantaneously, and then tried to figure out how to do this. And then we had a lack of evidence-based information. When we did get information, we embraced it today, and 2 days later it changed because we were all learning, right? Do you remember when the pandemic first came out and they said masks weren't going to do anything? Like, you know, if you don't have an N95, don't worry about wearing a regular mask because it's not going to do anything. And then when we ran low on N95s, what did we tell the nurses dealing with those? Put a mask on. And now we're trying to convince them that what we told them a month ago is now not true. And the issue is we wonder why there wasn't trust. We wonder why there was divide in this country because no one knew. And instead of just embracing that we didn't know, embracing that we're learning and living this right alongside of our patients and we're doing the absolute best that we can, we had to try and convince people that we didn't embrace we didn't know, and we covered it up, unfortunately. Alternative care models. So primary care, which nursing has been doing for quite some time, went out the bedside really quick. Done. The main reason, we didn't have enough ICU nurses, and every patient that was admitted with COVID, nearly every patient during that really big surge ended up being an ICU patient very, very quickly on a dime. So we had those ICU nurses in charge of a team. And I'll tell you that the hospitals are still looking at that model, and how do we embrace that model because we don't have enough? How do we bring LPNs back into acute care? Because we kicked them out, right? About a decade ago, we said, you know, we're going to embrace an all BSN, and we said no more LPNs. Misinterpretation, by the way, I'm here to say, a misinterpretation of Magnet. Magnet, for better or worse, it was interpreted that every Magnet facility had to have a certain number of baccalaureate prepared nurses, otherwise they weren't going to have Magnet. And although it says that you need to strive for that, there was never a number placed in there. So when we pushed our LPN colleagues out of acute care, which all that did is prevented us from educating them into acute care. And then when long-term care wasn't hiring, then those programs became stale. Many of them closed. And now we're in an issue where we're pulling LPNs back into acute care. They're not prepared for acute care, and we're leaving our long-term care facilities with a deficit in staff. So robbing Peter to pay Paul. Use of agencies didn't turn on the news in the last couple of years, where you didn't hear about travel nursing and what that meant. And the issue was they did what they had to do, right? What are you going to tell patients? You're admitted to the hospital and you don't get care? That's not going to happen. The issue is we live in a capitalistic society, so anytime there's an opportunity to make money, we're going to make as much money as we possibly can, and that's what those agencies did. I can have private conversations about the RN salaries, because I didn't have any problem with how much the RNs were making, but I did have a problem with the amount, the disparity between what the nurse who was working in the hospital was making and what the agency was making. That was where the disparities happened. Lots of bonuses for extra shifts. So what did lots of bonuses for extra shifts? It helped a little bit, but it sure did accelerate our burnout. We found we had to rapidly figure out how to train for team, right? And they're still struggling. Emergency onboarding programs, they were pulling those ortho nurses in and trying very quickly to get them up to speed to figure out how they needed to be, they could function in a more critical aspect. We were leveraging the staff, those critical care nurses, so I were terribly short, and the burnout was so high, and I've got some data here for you about the burnout that's as a result. And then the online resources were a huge issue. Trying to figure out how we put in place very quickly where they could go and learn what they needed to learn, right? Boil it down, give me bullet points, that's all I need. I just need to get through this one situation. So how do we do it? We did increase float pools. Hospitals are now starting to create their own agencies, in-house agencies, to combat that issue, because nurses like that variability. They like to be in control of their shifts. And we need to look at providing a multi-specialty nurse. That's the new conversation, is we no longer, that specialty track, we need to have a nurse who has the ability, that's more of a generalist, that can go everywhere. How do we do that? So good, bad, and ugly. Economic impact, we know as a profession, or as a healthcare, was sorely impacted. And what it resulted in is a lot of furloughed individuals that ended up finding other places, not just nursing, but healthcare. As they were closing units, our techs left, those individuals, those secretaries left. They went on to find other positions, and we can't get them back. Closed entire units that some hospitals aren't planning and never plan to bring back because of the loss of revenue. And then we have seen entire facilities close more and more. Current staff shortages. These are your staffing shortages for acute care, post-care. These are positions that these nationwide that they say are open. 87% of the acute care facilities say that they are currently short of their budgeted number of FTEs. Post-acute care, 92%. Ambulatory care, 76%. These are the number when you look at younger nurses choosing to leave the profession. Agency use is declining, but what we're finding is the thought is as those pay rates go down, as that demand goes down, those nurses will come back. We are finding they're not. They are not coming back. Nurses leaving their profession, when you look at the number of nurses we had in the profession that were 50 years of age or older, those numbers have declined 1%, right, from pre-pandemic. Only 0.5% for that 35 to 49 year age. Look at the 25 to 35 year olds, guys. The number of those individuals in our profession that are actively working now has decreased by 4%. This is the critical care nurses. Only 40% of the individuals who did this survey said that they were happy and satisfied being a registered nurse. 67% said that they were intending to leave their position within the next 3 years. So we always have talked about the churn, right? There's always that churn. It is happening. It's speed happening. You guys are going to move out students, and as soon as they get out and get acclimated, if we don't fix the systems, they're going to be leaving. That's our issue. This is nurse practitioners. So we encourage nurse practitioners, we need to realize that they've suffered the burnout just like their RN colleagues. For the issue that I see is that 62% are more burnt out than they were when COVID was at its absolute worst. This was a survey in 2022. And when they look at depression, right, the issue of burnout and depression go hand in hand. So we have a lot of work ahead of us, and facilities have a lot of work ahead of us. But so as I lay it really deep, I need as my mama would have said, I need my hip waders on to wade through all this depression. I will say to you, there's a lot of positives. And we, as a profession of innovators, of nurses who learn to do things, we have the ability to make a huge difference. We have to embrace this incredible amount of disruption that we've had in our lives. And I challenge you to not focus on older education models, to embrace new ways of doing things, figure out how we invest in innovation. We need to forget about those manual tasks that registered nurses have done for years and figure out how we work in teams and we use our skills and abilities to do what we are supposed to do, and that is care management. It isn't about taking a blood pressure. It isn't about those manual tasks. It's about our ability to critically think through processes the way others cannot. And we are going to have to, hospitals are going to have to give up those 12-hour shifts. Now, as I say that, I know that there are nurses who say they want it. And the ones that are currently working, those 35 to 49-year-olds, they want that. But these younger nurses do not want 12-hour shifts. You're going to be lucky if we're going to be able to get them for an 8-hour shift. They want to pick and choose. And the sooner facilities learn to embrace that self-scheduling model, the better it's going to be for them. Think about how things shifted in an instant in the pandemic. We were able to, if you wanted to make a change in your facility previously, there was probably 15 hoops you needed to jump through in order to get it done. And as soon as the pandemic hit, it was like, we need to do this. Okay, how do we do it? We're doing it tomorrow. It was embraced and put into place tomorrow. We need to figure out how do we do that more skillfully and without all the angst that comes with change. Embrace the changing workforce. Know that they value flexibility, autonomy, and support from their employers above all else. That's what all the surveys are saying. I want flexibility. I want to be respected for the work that I do. I want to be paid appropriately. And I expect my employer, if I lose a patient, for them not to tell me to just go to the next patient because the patient next door needs something. Give me a chance to process it. I am a human being. And as a human being, I need to be able to process that. So how do we build those into our systems? And then we need, as a profession, to learn to be bold. We need to learn to ask for what we need and not be afraid of embracing change. So let's talk about some priorities. I'm going to skip over a few of these because I see that my time's running low. But we do need to address the global shortage. Remember I talked to you about ethical recruitment? We have to figure out what that balance is. If a foreign educated nurse wants to come to the United States, we can't shut them down and say they can't come. But we need to figure out ethical ways of bringing nurses over, and what does that mean and look like, and what are we leaving their home country with? The reality is we are a global society, and then creating those healthy work environments is a huge issue. One of my conversations with Dick Durbin, we were talking about how regulation happens, right? CMS has the most crazy things that they say you have to document as a nurse. And so we were talking about that, talking about prior authorizations. And a physician just astutely, after we were sitting there talking, we said, you know, out of an 8-hour day, well over 2 hours is spent just in documenting what we have to document in order for our facilities to get reimbursed, right? So 8 hours, you know, 5.5 maybe we're, you know, spending with the patient, 3.5, 4.5. And the physician said, well, so here's the question. So we always create these regulatory burdens because something bad happens and we're going to fix it by documenting it, right? Making people document. He said, do we ever go back and assess that it really changed the outcomes? And Senator Durbin just kind of looked at him like, I don't have that answer if you expect me to have it today. But all of us around the table went and said, you're right. I mean, we're constantly told, well, here's something new you have to document, but for every new thing you have to document, is there anything that goes away? No. We just keep doing it and we keep perpetuating it. So we need to start building systems when we're looking at regulatory changes. We need to build in that evaluation. Now, nurses know how to do that, right? We don't do anything without going through an evaluation process. That's the nursing process. So how do we build that into our regulation? So I talked to you a little bit already. I've hinted at what will it take for nurses to stay. Higher pay, better benefits, and better staffing. 57% said better staffing in 22. That was 50% in 2018. And in 2018, 50% is still pretty bad if 50% of your nurses are saying staffing is bad. This is for nurse practitioners. What will it take to keep nurse practitioners in the profession? They have to be compensated better, and compensated better is removing barriers to them being compensated. That's the issue. CMS has a lot of things that still say, they use the term physician because it was only physicians who were regulated for so many years. And it's so hard to get them to embrace a different language. Greater respect, because they oftentimes are hired into what they thought was going to be one role and they're treated as a glorified registered nurse. That's very depressing after you've spent so much time doing that. Increased staffing support. So it's like, oh, great, you are the APRN today, you're the provider, but you know, you were a registered nurse last week and a CNA probably before that, so you're just going to do it all for yourself. It's like, really? And then less patient load. They are carrying a tremendous load of patients. So nursing education. So how do we start? We've had these conversations before. We go back to the old. But how do we start building that pipeline, right? When is the right time to start talking to people about whether they want to go into nursing? And what are we doing as a society to prepare those students in elementary, middle school, and high school to take coursework that's going to prepare them to go in? How do we make sure that the education that they receive in the inner city of Chicago is the same education they receive in Aurora and Naperville, right? And so we've got to do that. We've got to increase academic resources, funding. We'll talk about that here in a second. We need to go back to that dual investment in adjunct faculty where there's shared roles and practice in academia, so that our faculty are paid appropriately, right? So we can figure out that. And the new expectation in everything that we're reading and that we're talking to students about is students expect their faculty to be actively practicing. They're seen as out of touch if they are not doing that work. That's the reality. So a hard one to hear, but the reality of what the future is going to bring for us. So how do we embrace those shared models? And then how do we start investing in learning models? So as we are creating this, how are we investing in that and then creating those systems so they can be replicated in other areas? We need to look at our curriculum, and I know as I say this, you all say, do you know what it takes to change the curriculum here in Illinois? It's a crazy hot mess with a stack of papers about this big. I've seen it before. You poor people sitting at the end of the table trying to get a curriculum change passed. But we do need to embrace changes. We need to look at that clinical judgment model, which we all know, guys, April 1st, NCSBN kicked off their next gen. That's what next gen NCLEX is all about, is clinical judgment. So as we're looking at that, how are we building that into our curriculum so that our students come out prepared for that? Those academia and practice collaborations, faculty staying current in nursing practice, training alternative care models, huge. So no longer are you doing your students a favor if you are preparing them solely for acute care. And guys, it's got to be more than a week. It's got to be more than an 8-week rotation. So how do we balance that? I don't have the answers. I'm just reporting out the things that are being talked about and said, is we have to figure this out. And when I say we, I'm not looking at just the educators, the deans, the faculty, the adjunct faculty, and even the students in this room. I'm talking about the profession. So academia needs to figure out how they loop in the practice area so that we are really current on what's currently happening. And the practice area has to get really comfortable with sharing that with academia, right? They have to carve out, that's a very deliberate exposure to sharing of that knowledge. We tend to get siloed. And in those silos, we do the profession as a whole a disservice. So how do we do it? There are good models out there, but we need to do it at an accelerated because change is happening so very, very quickly. Virtual reality, augmented and artificial intelligence. You sit and talk about this and people get scared to death. But the reality, this is our future, right? I know academia is probably talking about ChatGPT and how do you figure out whether a student really wrote that paper or didn't write that paper. We're going to have to figure out how we embrace these changes. And we, as a profession, help guide where those innovations are used in our profession and how it augments us and not replace us, right? How it augments us and not burdens us, because that's what you're going to end. And then we have to increase simulation. Here's just very quickly, I can do this without I'm not even going to talk about the slides. For practice, we're going to have to figure out how we staff acute care. Then we have to figure out how we create enough nurses who have the knowledge to work in the community, because we're struggling there. Because they're working independently. In a community, they're not surrounded, as new graduates, they're not surrounded by a bunch of other people that they can pull in. So how do we create that system? We do know, the research has showed us for a long time, for every additional patient we give a nurse, the patient's outcomes drop. So how do we do that? And I'm going to say to you, I've written 2 separate pieces with some really intelligent people staffing solutions for acute care. And I think that we wrote really great legislation. I built a system along with those experts that I really felt was the answer. They empowered nurses to make decisions. But as long as facilities continue to ignore their nurses and not empower them, that legislation isn't going to work. And what we're going to have here in Illinois in the next 5 years, if we don't figure this out, if systems don't figure out how to embrace and empower registered nurses, we're going to have ratios. No doubt about it. It's going to happen because nurses are going to leave. They're going to leave and we're not going to be able to replace them. So how do we do this? Because when I sit and have a conversation with the hospital association, and I do this twice a month, I say to them, how many hospitals aren't doing it this way? Because I participate in calls where they're doing it really well. I'm so excited by listening to the innovations and the excitement from the nurses on those nursing care committees that are driving the decisions about how their units are staffed. And they love it. But for every hospital that's doing it right, there's 2 or 3 that are just ignoring it, and they're not. We have hospitals in the southern part of the state in med-surg units where nurses are taking 10 patients apiece. Can't. It's not because the acuity is lower either. It's just because that's the way it is in their area. So how do we fix it? Because if we don't fix it, if we don't drive that change, ratios are going to happen. I'm going to be honest to say to you, ANA Illinois has had the research. And we made clear when we worked at the Hospital Association this last time that this is your last chance to get this right. And if you don't embrace this, we can't continue to ignore what nurses are telling us. And if it can't be fixed this way, then it's going to have to. I do not believe is the right, because my biggest fear with ratios, I might be proven wrong, but my biggest fear with ratios is we become a widget. Nurses become a widget. We're just a number. We're just a person that gets to fill a void because they're told that in a med-surg they're going to have 1 to 4 patients, 1 to 5. So where's the nurse's role in that decision making? What happens if I have 3 really sick patients and I need to decrease down? How is that going to happen? If they're not listening to me now, what are they going to do when they're mandated for ratios? So huge issues, huge, huge. So these are the 6 things that nurses told us in the survey that the ANF said that they wanted is standards for a healthy work environment. What would it take? Skilled and respectful communication. Sorry, I misspelled. True multidisciplinary collaboration. They want to make sure that they're interested in working as a team. They don't need to be siloed. They want to be team. They want effective decision making. They want appropriate staffing. They want to be meaningfully recognized for the work that they do. And they want authentic leaders. So leadership has to become a huge piece for us. Redefine, we need to redefine novice to expert. As we're beginning to push people out into the profession, I think to myself about those individuals who we educated throughout the pandemic and what they experienced and then what we know they didn't experience. So as those individuals are exiting, they're going to need more support in the practice side in order to get them up to speed. So how do we do that? So investing in residency programs is becoming a huge conversation. Ensuring competency across the continuum from both novice to expert, and then multi-generational workforce. We have to embrace that they learn and they work differently. So how do we do that? Because the issue is it's not like we're going to flip a switch and we're only going to have millennials tomorrow, right? We are in a multi-generational. So how do we do that? Nurses are patient advocates. I'm not telling you anything. This is my last. We're the voice for those who cannot speak for themselves. We can never, as a profession, forget that. That's our role. When we're at the bedside, when we're teaching, when we're in the community, wherever we are, we continue to be the voice for the individuals who don't have a voice. So for Illinois, these are the things that we're working on right now. Inadequate workforce data collection, workforce shortage, APRN scope of practice. Criminalization of errors is a big, huge fear that's talking every piece of legislation we're looking at. We're looking at an opportunity to plug in some language that talks about not criminalizing errors, and how do we do that? And then criminalization for providing reproductive services. The powers that be have decided that Illinois is going to be a hub for reproductive services. And the issue is as those individuals come here to get care, then we need to protect the people providing the care and the people getting the care, because those people who get care are they're coming here because they can't get that care somewhere else. And the issue we have is what happens when they go back. Here's our workforce data that I told you. 46% in 2020, 46% are over 55 years of age or older for LPNs, 52 in Illinois for RNs. 70% of faculty were 55 years of age or older. This is the one that has me the most scared. When you looked in 2020 to the number of nurses that we had who said they were leaving the profession and the number of nurses that we graduated from programs, we calculated that we were going to be short 15,000 registered nurses by 2025. Guys, that's 2 years from now. During the pandemic, Governor Blagojevich, oh, wouldn't he have a kid? Governor Pritzker signed an emergency order that allowed nurses from other states to come in and fill a void. Did you know, if you go on IDFPR's website, that ends May 11th, by the way. There's 15,000, just under 15,000 registered nurses that came into the state to help us. As of May 11th, if they have not submitted an application for endorsement in the state, they leave. We had 15,000 shortage. We needed 15,000 to cover our void. That's a potential of 30,000 nurses we're going to be short in Illinois. These are the pieces of legislation. I have bill numbers for all of this. If these bills haven't moved through the legislature already, then they're dead. We have, the only thing that hasn't moved is the funding for faculty and the increased numbers for faculty and capacity and preceptors. And not because they're dead, but because we're looking to put those into the budget, into appropriations. Sometimes we introduce a bill just for the talking points of it, without that it's never going to get passed. It just allows us to talk to legislators and then begin to have those conversations of how do we slide this into the budget, right? And the governor has proposed a budget, and now the legislators have to appropriate the monies from those different areas into that. So that's what we're looking for. Mandatory data workforce, that's House Bill 1615. That's ANA Illinois' priority. That is going to require the Center for Nursing Workforce in Illinois to collect data. Every renewal, we're going to have supply data starting in 2024, and by 2027, they have to start doing demand data. So not only do we know how many nurses we have, where are they working, how many hours are they working, what setting are they working, we will know what facilities need them, because that's the other thing we don't have. And we can't adequately plan for the future workforce if we don't know the current. What we hear now, you have 200,000 registered nurses in the state of Illinois. That's more nurses than we've ever had, Susan. Well, I get that, but I don't know if they're working. I mean, I get a phone call at least every other month from some family member who is grieving the loss of their mother or their father and said, my mother was in the middle of renewing her license when she died. It was so important for her to renew her license. Can I do that for her? And I'm like, no, sorry, no. So we don't know. And I don't want to remove the right? Because for the very first thing, whenever you try to fix something, the very first thing, gut reaction. The legislator looked at us and said, well, that's fine. We'll just, if they don't practice, they don't get to keep their license. I'm like, okay, that's going to go over like a lead balloon, right? We are nurses to the day we die, many of us. Now, as the generations change, that might change, but for right now, that's the way we live. So all I'm asking for is for you to require them to answer a few questions when they renew their license. And so that'll happen. We also are working for APRNs, your psychiatric mental health nurse practitioners. We were successfully negotiated a bill. We wanted to get rid of consulting physicians completely and really truly have full practice authority in the state, but they're petrified of opioids. And so I did get the requirement removed for benzodiazepines. So currently, if you prescribe benzodiazepines and or opioids, and you have a full practice authority license in the state, you have to still register a consulting physician. Benzos are going to go away, which is going to be a big relief for our psychiatric mental health nurse practitioners, because they will truly then have full practice authority. All right, there's my references, which you can't read. I did give permission for the slides. For those of you, I saw a few of you taking notes. My slides are not secret. Please feel free to share them for everybody. Lots of information. I get off on tangents, which means I have to glide over slides at the end, but you can go back and read those. Is there any questions you have for me? I'd be happy to answer them.
Well, I have many, but I'm not going to take up your time. Anybody from Lewis knows I always have 5. Ask Dr. Muller in the back row. Okay, but I know you're running and I don't. My biggest concern is the number, because we have to get graduates, and so we understand that post-COVID we had a lot of changes in the pass rates of the colleges, right?
Yep.
Okay, and I recognize that at Lewis we were teaching with a shield and a mask on, and we were in, and we didn't do all the simulation. So I hear your slides saying sim, but again,
it's a balance.
The outcomes of 2 years of sim and shadow health and all these other things is makes me a little nervous, because on the other side of this building we talked and they said you really need more experience with just communicating with humans, families, patients, professional communication, teamwork, collaboration. So it's a balance is what I want to say. So
it is definitely a balance.
We're still in the 90s, and I'm thanking God every day, because we do, we limited. We do SIMs. Every level of Lewis has a SIMs, but it's not strictly SIM. Do you see what I'm saying? And so I'm worried about that.
If the interpretation that I was pushing that it needed to be all SIMs, that's not the issue. We've got to figure out what that balance is. NCSBN says that 50% can be. Illinois, you can only get to 50% in Illinois if you ask for a waiver. Right? You have to go in and ask for it. It's not that you can't get there, but you have to ask. So we have to figure out what that balance is, and we have to figure out what the students aren't seeing. I think that's the bigger issue. What are they not experiencing, right? That they need to experience, and how do we supplement that with the SIMS lab? Like my experience with OB. So, you had a question?
I have a question about, my students, I teach at the senior 1 level, and they tell me that they want 12-hour shifts. A lot of them work in healthcare, and they have 12-hour shifts, and they like the idea of only going 3 days a week.
What's your age bracket of your students right now?
Oh, so they are in their early 20s.
And they want 12s.
And they do.
Let's see how much they will. I'm just going to be honest to say to you how much they want 12s after they get out into the real world and take the patient loads that we're requiring them to do. Because those 12-hour shifts oftentimes turn into 16-hour shifts by the time they document. So I think that there's going to be some room for that.
And I'm asking, what is the alternative? Because they didn't like the 8-hour, 5-day-a-week thing, and the 12 hours is a burden. So what's the alternative?
Well, the alternative is that's being pushed in some of the learning centers are self-scheduling, giving them the flexibility. If they want 12s, let them have 12s, but not be afraid to say that you decide you still want to stay practicing, but you know what? I only want to do 4 hours. So the 3 of you get together and you share a 12-hour shift. And why should we be afraid of that? Why should we not embrace those things? So those are the conversations that we're looking at. I mean, we're really looking at, and it's radical and it's not going to happen anytime soon, but you move away from the registered nurse being an employee and the registered nurse being able to really be a traveler and go wherever she wants to go, right? You figure out those systems where we become independent contractors and we control our schedules. I mean, there's, as you all look at me like, really, truly? I'm just saying, we have to think outside of the box and we have to embrace it, try it, and if it doesn't work, I'm all in the data. If the data shows it doesn't work, then don't be afraid to fail. I think that's the bigger issue that we have. We don't try new, exciting things because we're afraid of failure. Well, so what does failure do? It teaches us what we need to do, and then we just try something different. So we need to be more nimble. We have to be. And I think as we get into this next generation, it's going to be even more evident that that's what they need.
I think the big word in all this is evaluation. You said it's part of the nursing process.
Yep.
I teach AdPi, which is going to be changing too. But the bottom line, I think there's been so much change, so many changes across the healthcare systems, that it's almost impossible to evaluate and to really see what is making positive impacts and what is not.
Yep.
And so what you're discussing on these slides is more change, right?
Yep.
Yet we have to. I mean, you can see the numbers and you can see the future. But I think the piece that's been missing, and I've been saying this for 10 years at Lewis, is that evaluation is a huge part of implementing something and then making sure the data does support that.
But what is the change that we have had? A lot of the change that we have had happen to us has been foisted upon us without our input.
Yeah.
Without us saying we'd like to try this, setting it up as a pilot and running with it in a certain unit, and then evaluating it and deciding whether it works. I mean, that's what they're doing for LPNs. I've worked with 6 different hospitals in teaching them what the LPN scope of practice is and what LPNs can and can't do in acute care again, because we've all forgotten, right? And they're running them as pilots. They've been doing it. And they do it in a single unit, which is what I said. Don't put this out system-wide. You need to do it in small scale, figure out if it works, because the bigger issue is going to be those registered nurses working with those LPNs and how they learn to work in a team again, because we haven't. So how do we do that? And that's been working. And then they roll it out to the next unit and the next unit. And so that's the secret. Whenever you put a nurse, I'm 100% truly from the bottom of my heart believe this. Whenever a facility wants to do change, when they bring us in and they ask our opinion and they ask us to give feedback and then they actually listen to our feedback and incorporate it, we will be less afraid of change. We will be less resistant to change, because we were part of it. I think that that's the bigger piece that has been missing, and then the evaluation piece. Because a lot of times we do change because we have no other choice but to do it, not in the ideal circumstance of being able to evaluate it as well. You had a question.
Well, you spoke a lot about staffing by acuity. Has there been any discussion on billing by acuity? Instead of the whole hours per patient day and build your whole unit budget based on the midnight census?
I would love to say that that would be happening here in Illinois, but that's our national level work. So all of that is CMS driven, and it's a huge burden to try and get that. We are talking about building value in at the ANA level, having conversations with CMS about what pieces of the pie can we bill for that nurses do. Because for nursing, the larger issue is we're buried in the room cost, right? Nowhere does anyone ever see that they were cared for a nurse. And so we're looking to how do we build that value and what pieces of the care that a nurse provides can be billed for. When we are successful in doing that, that's when hospitals will value our opinion. When we are revenue generators instead of what they see us as, unfortunately, wrong, yes. I was going to say wrong or right because it's not right. So completely wrong, they see us as a revenue drain because we are a cost center, not a revenue producer. So one more question, and then I know Pam has plans for us to go out and tour. So one more question. No, go right ahead. Come right ahead.
It's more just a comment I feel as a nurse myself. I think that I would prefer, part of it is I don't think we get enough aggressive support nationally to help protect nurses. We are, at the end of the day, anything goes wrong, it's on us all the time. And we're already, we've got stress because we're taking care of our patients and we're already worried about it. But to know that, and you brought it out in the slide about criminalizing, and that's honestly, we have that stress. There's very good reason why a lot of us are leaving the field. It's because we are the scapegoats. Do you see them going after the physicians as much? No, they come down and it's on the nurses. And I think part of the problem is we really don't feel that we're getting, and we saw those cases in the past few years. I just don't feel that nationally we're getting as much support as we need to aggressively stand behind nurses in that type of scenario. And so that's part of why a lot of us are afraid to make the change that you're asking us to do. And part of the issues that we're having with all these shortages is because of that as well. On top of being overworked and having to deal with the administrators and physicians and not having the respect. I mean, I know physicians' assistants are getting more respect than nurses, you know, and
I don't ever be afraid to use your voice to tell us the truth, because everything you just laid out for us is everything that we have heard. And I will say to you, our biggest downfall in nursing is our division amongst ourselves, right? We are siloed in specialty organizations, in nurses unions, and professional associations, and then we go out there and we all are doing our own thing. I will tell you, I know I'm constantly having conversations at the ANA level when things come out and we say, because we have 124 staff people running the American Nurses Association, right? So it's a huge enterprise. But the issue is as a board member, something comes out and we're like, why weren't we on top of that? Why do we have to be reactionary? Why can't we be proactive? And the issue is things are happening, but they happen at a snail's pace at the federal level. And whether that's right or wrong, we do need to become more vocal. We're working on that, and we need to figure out how we work together. How we say, I'm going to agree to disagree with you on this issue, but on this issue, we have to stand united. Safety for nurses in hospitals, which is the violence that's happening, and staffing, we have to stand united in. If we don't, we've lost. So those are the two things that we're working to build coalitions on, and I think that you're going to be pleasantly surprised in the next. Jennifer Menzik-Kennedy is our new ANA president, and I think she's going to bring great change, and I'm really excited about the work that she's going to do. So keep using your voice, keep telling people what's wrong, because when we don't tell people what's wrong, they assume our silence is consensus. For every one of you in the room, I can't tell you how much you need to realize that when we are silent, we are perceived as consenting to what is happening. I tell students that all the time. Silence is consensus. I tell my grandsons that when they talk about bullying. So when you watch Johnny push Joe down the stairs, did you say something? And we need to do the same thing. When we see somebody injured, disrespected, treated poorly in our profession, we need to stand up, we need to say something. So thank you very much. And thank you for agreeing to speak out instead of not speaking out. All right, Thank you all for listening. Now for your tour.